Thank you to all the speakers for keeping to time, because this gives us a nice chunk of time at the end of this session to have some discussion and questions. The work that colleagues have been describing over the last hour, as they've conveyed, are large programs of work that have been going on for many years, so we've really scratched the surface of the insights and knowledge we can glean from them. So what I want people to start thinking about some of the questions. What did you hear that interested you? What do you want to hear more about? I thought there were some fascinating questions to ask about. What are the skills that board members need to ensure their organisations improve quality? How can we ensure that we're building a patient voice into the design and the delivery of our services, and what can we learn from where that's been done well? I think there's a really interesting question about how we can evaluate the impact of improvement efforts, and given the sort of long-standing nature of the work that's been going on in these countries, how can we learn from the way they're evaluating impact? So hopefully others are starting to think of some questions they would like to hear more about. What I want to suggest is that we just take 3 or 4 minutes for people to have conversations with colleagues. If you're sat on your own, perhaps you can shuffle up to somebody else, have a conversation with them, or reflect yourself. Please do send your questions and thoughts through on Twitter. If you don't tweet yourself, perhaps you're sat next to somebody who is tweeting. We're going to have 3 or 4 minutes for you to reflect on what you've heard, and then we'll have some discussion with the panel members. Okay, hopefully that's given you a chance to think about some of the questions you'd like to hear. We've had some questions through on the Twitter feed, and Omar, who's been on the stage with us as our information DJ, is going to go up to the podium and put some of those questions to the panel. There are microphones at each of these stands, and they're all live and active, so if anybody would like to ask a question in person, please do go up there, and I'll call you when I see you. So Omar, thank you, if you'd like to.
Hi there, my name's Omar Sadiq. I'm an anaesthetic trainee from Kent. I've been monitoring the Twitter feeds and also the feeds from the internet across the nation and worldwide. There's quite a few questions. First, I'd like to start off to all the speakers. Will any of these healthcare improvements translate across the border?
Oh, great question. So,
Will any of the improvements translate across a border?
Yeah.
Presumably from country to country, is that the question?
Yeah, so will any of the improvements translate across the border? So,
yes.
Mansel.
Yes, actually, yes, my Celtic colleague.
So, any specific thoughts on that? On how we could transfer them?
By having organisations like this, having meetings like this, and talking to each other.
Yeah. Is the microphone working? The hand microphone?
Is it on? Is it on?
Oh, sorry, maybe it wasn't on. Okay, yeah.
The first thing that strikes me is that my colleagues to the left and right of me operate within single improvement organisations in their territories, and I think the advantage of having bringing together the strengths of all of the organisations we've had previously into NHS Improving Quality gives us the opportunity to do that. So we're keen to learn from colleagues how to operate at a national level while allowing organisations locally the space to do what they do best, but support that across a national context with some clear goals. And I think from Northern Ireland in particular, the integration of health and social care is something which I think we can learn from and need to make sure we respond to in relation to the development of integrated care, which is one of our big ticket issues in England.
Yeah, okay. So, Paddy, thoughts you'd like to add to that?
No, there's absolutely...
It's on there, yeah.
It is on. There's absolutely no reason why we can't learn from each other. The populations that we deal with suffer from the same conditions, largely to the same extent, with the same modifying and mediating factors. We work within largely similar systems with identical practitioners, we just have to think about it. And the elements are there. Something such as this, okay, but I think again, a theme I think that came out in all four talk was about engagement, and engagement that I alluded to. Certainly, our safety forum has links with the south of Ireland and particularly with Scotland, but with the rest of the UK. And it's about developing those so we avoid unnecessary duplication, and the whole becomes greater than the sum of the parts.
Yeah. So Mansel, yeah.
I think I was surprised by the question, because actually, when you look at the history of all this, we're actually doing the same sort of things. We may be tackling in a different way and getting different successes and working in completely, well, they're not completely, but different systems. But actually, we are already doing that by transferring knowledge and experience across boundaries. And these sort of events really hit home, and particularly what we've heard today.
And also, I guess all of your 4 countries have resources on websites that other people outside of the UK can tap into and use.
So the only thing I would say, and I think England is special. So there's something special about the scale that you face in England and the way you have decided, rightly or wrongly, to structure your healthcare delivery system. So what I describe in the Scottish Patient Safety Programme exists in England. It exists in the southwest of England and in the northwest of England and in pieces of other systems. So pieces of it exist. The challenge in England, I think, is, as you well know, and that's why you've taken the job and that's why you're designing it the way you're designing it, is to take that to scale in a system that doesn't have a single integrator, like we have in the other 3 places. So I think there is something unique about the scale in England that the other 3 countries don't face.
Yeah, I would agree with that, and particularly I think the premium will be on more effective partnership working between organisations. So we see organisations, you had it on your first slide, Joe, I'm from the Northwest, so I'm very familiar with the work of Aqua, where organisations come together and self-organise and set testing standards for themselves. NHS Quest, an organisation of Foundation Trusts coming together to set the bar high on quality and safety. We need to encourage and catalyse that kind of activity, because the system in England doesn't allow a line management approach. It is made up of many different organisations with their own autonomy and governance lines. So we have to think carefully about how we do that. But arguably for the first time what we have got is a single improvement body nationally, aligned to the commissioning priorities of the NHS and committed to support the development of commissioning and indeed provision across a few clear goals which we set out.
Yeah, and I think that's an important point, the need to get that alignment between what the sort of top-down priorities are and the support to sort of bottom-up structures to do improvement.
Could I just very briefly, let us not forget we have colleagues beyond our shores.
Yeah.
And I know there are people here from New Zealand, I've worked with from Canada and from South Africa, and we can learn from them and they can learn from us.
Yeah.
And although systems may be different.
Yeah. Okay, so Omar, next question.
I've got an interesting follow-on question from that. There's a question, how do you spread and share innovation and improvement across organisations who are in competition with each other?
Okay, so I think this is particularly a question for England. The question was, how do we spread and share innovations between organisations that may be in competition with each other? So in England there is a developing market for healthcare, so providers will be in competition to provide services. Julian, is that something you would speak to?
Yes, that's a really key question that goes to the heart, I guess, of some of the challenges that we face. One of the responses to this in England has been the development of another new set of players known as academic health science networks, which bring together hospital trusts, primary care, industry, education, in order to promote innovation and improvement. And there are 16, I think, of those in England, just licensed, and they will be key integrators of the spread and development of improvement and innovation. And There are certainly high hopes for AHSNs, which is we're fond of acronyms in the NHS, Academic Health Science Networks, in order to drive innovation and improvement. The balance, the challenge will be finding the balance between local innovation, which comes from the ground up, and national prescription about what we must fix in the NHS and what we need to take forward. And I think that we'll find that balance, but that might take a little while to find its level. But they are very important, and as are the strategy that was launched in England, which gave birth to HSN's Innovation, Health and Wealth, which sets out the importance of the NHS connecting to industry and commerce and driving innovation across its breadth and length.
Great, thank you. Omar.
I have a question for this is NHS Wales. In Wales, how will they measure impact of the capability building, and do they have a healthcare outcome improvement aim?
Okay, the echoes of how will you evaluate the impact of the capability building? Yeah.
Well, I trust that what we will be doing and are doing to some extent.
I'm not sure it's on, Mansel, is it?
Yeah. What we will be doing is looking at the quality of the delivery that's being made by the people whose competencies, engagement, and whose education we're building. We have to do that in a hard way and looking at a number of factors. You can't just pick one and look at them and say, well, we've achieved this in capability. What we want to do in Wales is to actually use a focus on the individual, on the patient, to measure that. So we do things like mortality reviews. We look at quality improvement in the workplace. We have measures of those. They are benchmarks. And we therefore can use those benchmarks as hard measures, hard outcomes of seeing are we making any progress. And therefore we can relate that across workforce, we can relate that on quality improvement, and indeed patient satisfaction and the way the patient proceeds seamlessly through the system. It's not difficult to do that. I've often been asked, don't you think it's going to be impossible to measure quality? It's impossible to measure capability. It's not. As long as you've got some good hard measures in the beginning and you monitor thoroughly, then I don't see it's going to be a problem.
Okay. Omar, before we move on, it'd be interesting, Jason, to hear what you're doing in terms of evaluating impact in Scotland.
So it's a really interesting question, and there's a lot of science behind how you attribute changes like HSMR reduction or infection reduction to these huge social changes which we're implementing. And you can't implement a safety program without affecting the way trainee doctors work, without the way we do student nursing, it's such a multifactorial intervention. It's almost impossible to say this is the piece that did it. Göran Henriks, who's maybe in the room from Jönköping in Sweden, many of you will know him. When you ask Göran Henriks how has Jönköping become this beacon of quality in the world, he says we just did everything. It's a really simplistic response to, yes, we do the trainee doctors, yes, we do the student nurses, yes, we do the bundles in critical care, yes, we do the person-centred care thing. The evidence exists. You don't need to reinvent that evidence for your particular context. What you need to reinvent is how to do it in your particular context. But we already know that if you do all these things, this quality will happen. There is still then evaluation to be done of what's actually happened in that environment. And we have worked in Scotland for multiple PhD students on how the safety programme and whether the person-centred care work has done what it appears to have done.
And I think also there's something about not just evaluating the impact of the work, but understanding what some of the kind of critical ingredients were.
Pieces of it.
Yeah. Okay, Omar, the next question.
Final question. 18 days into NHS reorganisation, have any patient journeys materially changed?
Okay, so Julian, I think this is another question for you in terms of 18 days into reorganisation in the English health system. Has anything changed?
I'm so glad Julian's here.
I think that an awful lot has changed, whether it's changed in the last 18 days or not, but certainly a lot of health systems have changed the way that they work, not just since the reform agenda, but prior to that. So in order to deliver the improvements that I was talking about previously, organisations and systems have had to redesign significantly. And if we think about the urgent care challenge and the levels of urgent care demand that we experience, the responses to that, particularly in primary and community care, certainly in my experience of working in a busy urban setting, have changed significantly in terms of much more effective relationships with social care and primary care. The vertical integration of services where acute hospitals have taken on community services has helped to streamline the management of urgent care in many areas. My sense is that that will just need to accelerate following the formal establishment of clinical commissioning groups, because what clinical commissioning groups will have, being clinically led, will be visibility at a very local level, at a patient level, on what's happening and what's changed and what's going on with each patient. And furthermore, the plan is that more and more information becomes publicly available, including outcome data by consultants, so that clinical commissioning groups and the public themselves are more informed, information is more transparent, people have access to their health records, and all of these things that I've seen in pockets. I've seen some fantastic examples of this up and down the country. The challenge is, how do we scale that up and make that common practice and standardised? And that's where our learning about what works in terms of change really matters, and that's why we focus not only on doing the doing, but understand what it takes to make things happen. And that's the point about not just applying rigorous delivery as one point of the diamond, but also engagement and leadership and all of the cultural components that surround the delivery of great healthcare.
Okay, thank you. So that's all the questions that we have from Omar. I just want to say thank you. Some people have tweeted with links to where you can get some of the resources that have been being described by the 4 countries. We've got a few minutes, and I just had a question that I wanted to ask each of the panel members to answer, which is in terms of the responsibility for leading for quality and safety. Obviously it's something we all have to enact as an individual responsibility, but also it's something that leaders of organisations, are critically responsible for. And I'm just interested in each of your comments in terms of what do you think the key responsibilities and skills that boards need of the organisations in your systems in order to ensure high quality care. So what are the skills that boards need in order to ensure we have high quality care? Jason, if you'd be happy to start with that.
So it's tricky to go first. Maybe you haven't given me long enough to think. So let me try and do it around one of the models we use in Scotland, which is our 3-curve model, designed partly by IHI and partly by Derek. And it talks about performance being the foundation. So you absolutely need execs and non-execs who can understand financial balance. You can't have the thing go bust. You have to meet the government targets, although we have very few of them now in Scotland. We used to have 200 and something, now we have teens, we have 16 or so. So there's the performance level, so the board has to be responsible for that performance level. That's curve number 1. If you imagine then another curve coming from that curve, that would be our improvement curve in Scotland, and that would be around understanding statistical process control, so you know what you're looking at. That would be new skills around board members walking around the healthcare system and finding out about safety and quality, and interviewing patients and families, interviewing staff, interventions around the boards on board agenda, which we've done in Scotland. And then the most revolutionary of all is the 3rd curve, which we're moving to now. In the early years is a good illustration of co-producing the change with patients and families and communities, and board members being able to, as lay members, particularly the non-execs, obviously lay members of the citizens groups, helping us to do that co-production. So I think in Scotland we think of the skills of the boards as we do in the skills of our staff around those 3 curves.
Okay, well that's great, Jason, and that was without any preparation, so if we'd given you preparation, goodness knows what we got. But anyway, Mansel, would you like to add anything to that? You were talking about doing capability building for boards.
First of all, I must agree with what you've said, but when you were before and when you were saying it, I was adding my own. And again, going back to what we heard from Robert Francis yesterday, if you read his report, not all of it because it's very, very long, but the executive summary, then you'll see that all the things that has just been mentioned are mentioned by him. But more importantly, and you did mention it, I think walking the job, if for want of another word, going around and seeing things as they are. We do encourage that in Wales, and in Public Health Wales, our non-executives or our executives make a point of going out and talking to the people and talking to the staff. That's extremely important. The other thing is the co-production, working with others to produce the final product, if you want to use that word, and then using a very general and generic term, and that is good governance. Frequently, when I am on an interview panel, I ask people, what will they please define and describe what is meant by governance? And about 9 out of 10 don't know that. I think our board development in Wales ensures that governance, what it is, what it should deliver, what accountability means, are the very issues that we try to get across to both executive and non-executive board members. Okay,
thank you. Julian?
I would absolutely agree and underline the IHI Boards on Board programme. Having been through it twice with 2 different boards, it's absolutely excellent in terms of engaging the whole board, not only in the intellectual but the emotional challenges of running a healthcare organisation and the importance of engaging with patient stories, patient safety walkabouts and all of those things. I would add to that list the ability to manage risk effectively and having really, really strong and effective risk management systems at the board table where you have visibility from board to ward on key indicators and clarity of measurement. The third thing I would say would be that you have to pay attention to the dynamics within the boardroom, particularly between executive and non-executive, spend time together, work on the dynamics to create a healthy climate of honesty and challenge in a constructive sense to ensure that all issues and problems are on the table and are addressed in a way that doesn't leave issues submerged or hidden from view.
Great. And Paddy?
Nothing really new to add from that, other than they need to have crystal eye-watering clarity around what their role is, and it's largely around ensuring the governance of the organisation, that the organisation does what it's set out to do, and be at the same time supportive and challenging of the executive in terms of management of risk. Dealing with information, I think, is critical, and they're kind of empowered to ask the stupid questions and shouldn't be afraid to ask the stupid questions. If they're presented with something that they don't understand, they can't discharge their role, and they are duty bound to reflect that back and seek information around how the organisation performs in a manner that they clearly understand.
Great, thank you. So some great thoughts really there on the role of leaders in improving quality. So our time is up. Just want to thank all of you for coming along. I hope people have found useful learning from that, and I really would encourage you to go to these organisations' websites to learn more about the work they're doing. Thank you to Omar. Thank you to the 4 speakers. Thank you very much.